we are so thrilled that we have 3 of the top neurologists in FOXG1 with us today. These are the neurologists who see the most FOXG1 patients around the world. And I mean, what a dream come true for me Thursday night to be able to talk to all 3 of them at once and ask all my Josie questions. If there's any reason why I'm doing this, it's to have them all 3 together. So you will have questions. They're each going to present one after the other, and after all 3 present, we will do a Q&A. So write your questions down. There's notepads in front of you. And without further ado, I'd like to introduce Eric Marsh again, he runs the Rett Clinic Center at CHOP. And
thank you.
Yes.
Thank you for inviting me. So yes, thank you for inviting me. And today I'm going to talk a little bit about seizures in FOXG1, but kind of seizures more broadly, because one of the things that I think happens when parents see their neurologists is the neurologists use terms that they don't define to the parents. And so that the parents are told, count generalized tonic-clonic seizures or this or that, and there's a real distance between what the neurologist is saying and what the parents are seeing and what the parents are saying and what the neurologist is seeing. So I think it's important that, for an audience like this, that we can kind of define some of the terms that we're using so that we're all on the same page. So I'm going to go over kind of epilepsy kind of broadly and seizure types and how to recognize them more specifically, then go into kind of epilepsy in FOXG1 syndrome. And I'm really curious what's going to happen because the little bullet points changed to something interesting there. I'm afraid to see what's going to happen moving forward, but we'll see. And then talk about treatments for. It's a fish for me, right? I did not do that though. So talk about treatments kind of broadly. Unfortunately, I'll show a little bit from the natural history, the NIH-funded Rett and Rett-related disorders natural history study about what medications have been tried in FOXG1, and then questions, as Nicole said, will be with all 3 of us together. Oh, wrong direction. All right, so epilepsy is common. So epilepsy is the 4th most common neurologic disorder. About 1 in 10 people will have a single seizure in their lifetime, and about 1 in 26 people will develop epilepsy in their lifetime. And that includes your children, right? So that number includes all these kids with severe neurodevelopmental disorders too. About 150,000 people are diagnosed with epilepsy each year. And unfortunately, across all comers, but higher, as I'll tell you in a second, in these neurodevelopmental disorders, about 30 to 40% of people will have active seizures because the medications that exist don't work, so that we need better treatments for individuals with epilepsy. So first and foremost, what is epilepsy? So epilepsy is a disorder characterized by recurrent, unprovoked seizures. And recurrent means that there's 2 or more. Unprovoked means that it's not caused by any other factor. So if you go on a drinking binge and you wake up in the morning, you have a seizure, that was provoked because you're withdrawing from alcohol. So these are no other cause, not that it has happened to anyone in here. And then epilepsy and seizure disorder are synonyms. A lot of people don't like the term epilepsy. Historically, epilepsy was a bit of a closeted disorder because people, if you go back into the 1800s, people thought that people with epilepsy were witches or possessed by the devil. So the term had a really bad stigma. And so for a long time, people were saying, oh, I have a seizure disorder. But epilepsy and seizure disorder are the same thing. So then what is a seizure? Well, a seizure is when there's synchronous abnormal electrical activity in the brain. So your brain normally is firing all different things. It's taking in the environment. It's taking in your thoughts. It's firing all differently. But if it starts to fire synchronously, that the whole brain starts to do the same thing at once, that is what we define as a seizure. And like I said, seizures can be provoked by many things, such as fever, drugs, alcohol infections, a bleed, or a stroke. But when you have them without any provocating factors, that is defined as then epilepsy. So one of the things that we deal with in FOXG1 and all these neurodevelopmental disorders is it a seizure? Because a lot of your children will have really unusual movements. And I'm not going to go into much of this in detail because Drs. Benke and Bahai are going to talk about this more next. But the EEG is often abnormal in children with FOXG1. But that doesn't mean that they're having seizures. You can have an abnormal EEG and not have seizures. And then there are some people who have a normal EEG and actually have seizures. So it doesn't mean the two. And you shouldn't treat the EEG. At least as we know now, we don't have any evidence to suggest that we should be treating the EEG. You treat the patient. You treat to see if they have seizures. And often, in order to make a diagnosis, that you need to have an EEG capture an event and show that there's this synchronous electrical activity in the brain. And video EEG recording is often the best way to do that. But now just capturing the event on video and sending it to your neurologist can be very helpful. So if it's not a seizure, what can it be? And like I said, I'll just go over this really quickly because you'll hear more about this, but it could be a movement disorder. It could just be daydreaming and decreased responsiveness. It could be just stiffening because they have an itch on their back or something like that. So there's a lot of different things that can be seen and be recurrent events that aren't seizures. Then how can you tell it's a seizure? Well, like I said, the gold standard, the best way is capturing one on EEG, but there are some clues that point to things that are a seizure, such as if there's no response during a spell, if they go to sleep afterwards, if the movements are always the same exact thing and they're not different from time to time. Clues that it's not a seizure is that they're looking at you and making eye contact during a seizure, that the events are not rhythmic or not reproducible, or if they go right back to baseline. Now, with saying that, all those could be not true. So these are just hints at what is a seizure. It's not definitive. So this is where nowadays with the cell phone video, getting a video and capturing it and sending it to your neurologist is very helpful because then the neurologist can look at it and see what they think. But the truth is that if you show a lot of these videos to multiple neurologists, half will say it's a seizure, half will not. A colleague of mine gives a lecture at a course for young neurologists, and he shows videos where he has the EEG, so he knows whether it's a seizure or not, and he asks everyone to raise their hands, seizure or not, and pretty much everyone gets it wrong. So this is a challenging thing to deal with, and particularly in FOXG1, where there are so many other movements, it becomes particularly challenging. So the other thing that parents deal with a lot when you do have epilepsy is that things can trigger the seizures. So that even though these are recurrent, unprovoked seizures, there are things that can make it worse or make it better, like medications. So missing a dose of medication, being a very stressful situation, sleep deprivation, and the other things listed here can be provocations of seizures. And I've heard some very unusual things that seem to be repetitive in different patients. Things like phase of the moon seems to be one that parents will say, when it's a full moon, my child will have a seizure. And you hear it enough that you start to believe these things. When I was first starting, I didn't believe them. But then over time, you start to believe some of these things. So now, so you made a diagnosis of epilepsy, you have a seizure type, and the neurologist will say, well, your child has a focal seizure. Your child has a generalized seizure. So what does that mean? Well, seizures can be classified either as focal or partial seizures. The other term that people use are localization-related epilepsy or localization-related seizures. So there's a lot of terms to say the same thing, and that's partial seizure, and I don't know if this is working, but where it starts in one part of the brain, and I'll go into a little bit in a second. You could have seizures that start focal but then spread rapidly to the rest of the brain, and this is what we call a secondarily generalized seizure. And then you could have seizures where it seems to start in the whole brain at once, and this is what we call a generalized seizure. And for this, the biology is still, the underlying biology is still being figured out, but there's this idea that the thalamus plays a role in sending the seizure to everywhere in the brain at once, or deep in the brain plays a role to sending the seizure to everywhere at once. So then you have a seizure, and the doctor will say, do they have any warning or signs before seizure? And they call this an aura. And even kids who can't speak often will have a change before their seizure that their parents notice, that they become quiet or still, or that their eyes do something a little bit different that occurs before the seizure. And this is the aura, or that's happening. And what this actually is that the seizure is starting, but in a really small part of the brain that can't necessarily be picked up by EEG. And then you have the seizure itself, and this is the ictus or the ictal part of the seizure, and that's the term neurologists use for a seizure. And this is what is felt or seen during a seizure. So this is the actual seizure itself. Then there's the postictal state. This is when the seizure ends, the behaviors that can occur after a seizure. And many children will have a change in their behavior that persists after a seizure before they get back to their baseline. And in that postictal state, it can be confusing where you're not sure if the seizure is still going on or not. And unfortunately, some of the only ways to sort that out is by capturing one on EEG. So generalized seizures, as I said, start kind of everywhere at once. And on the right here is an example of an EEG of a child with a generalized seizure. And you see that the blue is on the left, the red is on the right, and you see that it's all the same everywhere. So it starts simultaneously everywhere. And this is what's called a generalized seizure. Generalized seizures typically present with motor seizures, and these are seizures where there's a part of the body that's involved. And the terms we use for this are tonic-clonic, tonic, where it's just stiffening, clonic, which is jerking, myoclonic, which is a brief jerk, or epileptic spasm. And the symptoms that go with this are listed there below. And then you can have non-motor seizures that are generalized. And these are absence seizures, so just a staring spell, or atypical absence, which is a staring spell that can be focal or generalized. And then you can have non-convulsive status, where the child just is not themselves and they're just out of it. They still might be responding a little bit, but are not themselves and out of it. And these types of spells usually last seconds, whereas the motor spells usually last under 2 minutes, but they can, of course, be longer. And then focal seizures start, as I said, in a single spot of the brain. So here's an example of a seizure that's starting in the left part of the brain and then starts to spread a little bit more broadly. If it's just really focal, consciousness may not be impaired, so the child can still be interacting with you. There can be involuntary movements, there can be sensory symptoms, there could be psychic symptoms, which would be hard to tell in individuals with FOXG1. And then there could be unusual things where they're acting out, they feel confused, et cetera. But then you can have focal seizures, that, go back one, I don't think it's on there. Oh. Weird, not on there. But you can also have motor components. So if this focal seizure is in the motor strip, the part of the brain that controls motor movements, you could have unilateral jerking. You can have movement that moves down the body. And then if it spreads outside that original area, you have what's called a secondarily generalized seizure. So this is a focal seizure that spreads to involve more of the brain. When this happens, you have a loss of consciousness or a loss of awareness during this. If it happens rapidly, it's often difficult to tell the difference between a focal seizure and a primary generalized seizure, and it happens after a focal seizure. The other thing that we talk about a lot in kids with neurodevelopmental disorders are epilepsy seizure syndrome. So you guys have probably heard a lot of the terms up here. So things like childhood absence seizure, benign Rolandic epilepsy, West syndrome or infantile spasm syndrome, Gervais syndrome, which is also known as severe myoclonic epilepsy of infancy, or Lennox-Gastaut syndrome. And I'm going to highlight Lennox-Gastaut syndrome for a second because Lennox-Gastaut syndrome is a term that describes a change in the EEG and a type of seizure that you have. So that Lennox-Gastaut syndrome can be caused by many different genetic causes or many different causes. And many kids with FOXG1 will develop multiple seizure types and have EEG changes that are consistent with Lennox-Gastaut syndrome. And the reason this is important to note is because there's been approval of a number of medications specifically for Lennox-Gastaut syndrome. So if you have a Lennox-Gastaut syndrome diagnosis, there's access to medications that you wouldn't have if you don't have that. So it is, if you then search Lennox-Gastaut, the websites are terrible. It looks not good, but then again, same thing with FOXG1. But it's not, you shouldn't, if your doctor says you have Lennox-Gastaut, that doesn't mean you don't have FOXG1, right? The Lennox-Gastaut, the pattern is due to the underlying FOXG1 genetic change. So what do we know about epilepsy specifically in FOXG1? So there's been a few papers that have been published that more broadly talk about the symptoms in FOXG1, or more specifically talk about the epilepsy of it. And I'm not going to go over all the data because it would take way too long, but in general, and Ellie kind of mentioned this before, that the number of the percent of seizures in most of these papers are in the high 70s to 80% range, but Ellie obviously showed you data where the number seems to be a little bit lower. And the difference of that could be because of the different genetic causes that are in there or other differences that can be seen by the way data sometimes is collected. And then the age of diagnosis, and this goes to, oops, hit the wrong button. The age of diagnosis, right, for deletions and mutations, and this is from the paper by Seltzer out of Rochester, where the age was about 20-something months for those with deletions and mutations, whereas duplications was much younger, and that's because these children all developed infantile spasms syndrome. And when you look at AED use, it was much higher in the deletions and mutations than the duplications, because these duplications often will outgrow their infantile spasm syndrome and their seizures. Oop. You got to get this right by the end of it, huh? So then in the natural history study, we asked questions about epilepsy frequency, types of seizures, et cetera. And so we had previously published a comparison of the 4 diagnoses that were in the Rett and Rett-related disorders natural history study. And these were typical Rett syndrome, atypical Rett syndrome, non-Rett with an MECP2 mutation. So those are all primarily girls with MECP2 mutations. And then there's MECP2 duplication syndrome, FOXG1 syndrome, and CDKL5 deficiency disorder. So this is looking at when they show up to the natural history study, what is the frequency of their epilepsy based upon their age. And you see the FOXG1 here in light blue gets up to about 75 to 80% had seizures in this cohort. And when we looked at this a little bit more carefully, looking at across the different visits, we found that about 78% of the individuals had epilepsy in our cohort. And then if you look at the age that they start by mutation category, see that the duplications do start at the youngest age, and the rest are, between anywhere from 6 months up to 5 to 7 years, and even some starting much later, with some individuals starting later at life having their first seizures. And one of the things that Ellie and I have talked about is comparing these two things and trying to put them together to see how we can learn more about it by understanding how the 2 different data sets were collected in different ways. So then seizure types in FOXG1. So again, focal seizures, generalized seizures, infantile spasms, myoclonic seizures, or events that the parent thought was a seizure, but when the doctor who was at the study site heard the story, they rated it as not a seizure. And so this is by mutation type, and I'm not going to go all of this because of time, but you see that generalized seizures is the most common. That was reported then by focal seizures. As you get older, or in certain this is by mutation type, in certain mutations, there's probably a lot of movement disorder in there that they were, parent was thinking was a seizure, but the neurologist thought was not a seizure. And then if you look at the same seizure types by age group, you see that generalized seizures become more common over time. Not a seizure becomes more common, and that goes along with Ellie's data showing that the movement disorder becomes more prominent over time. And then infantile spasms becomes less over time, or epileptic spasms becomes less over time. So then how frequent are seizures in FOXG1? So this is at the baseline visit, what was seen over the previous few months of time. And so we had 60% in FOXG1. So again, this is comparison of all the different disorders. 60% had ongoing seizures, and most of them were, monthly, weekly, daily, and there was a bunch with daily seizures just in the 3 months prior. And so Ellie showed some data which says that there's more frequent, but that was looking over a longer time period. So over the last 6 months or last year, this is looking over a shorter time period. So how do you treat epilepsy in FOXG1? Unfortunately, we don't have good data to say this is specific for FOXG1. What we see is that, the same, about 2/3 can become seizure, 2/3 will have a period of seizure freedom, but a third, I'm saying this backwards, sorry. Overall in epilepsy, as I said before, 2/3 are seizure-free on medications, about a third are what we call medically refractory, or they continue to have seizures with their medication. in FOXG1, it's a little bit flipped, where about 60% seem to be medically refractory, whereas 40% can be seizure-free on or off medications. So general principles of treating. So first, treat the child and not the EEG, right? Don't chase, if your neurologist is chasing the EEG, I would suggest don't do that, but you could ask the neurologist why they're doing that, because they might have a great reason for doing it. The goal, of course, is no seizures and no side effects, but in these developmental epilepsies, we know that the no seizures part is not going to be likely in most individuals. So it really is a quality of life. So you're striving for the best quality of life, the lowest number of side effects. You really want to try to avoid polytherapy. It becomes common, and I'm guilty of this as well, of starting person on one medication and then they have seizures, so you add a second medication, they continue to have seizures, so you add a third medication. And I really try hard not to do that, but often in the heat of the moment with the parent telling you that they're having 15 seizures a day, you just knee-jerk add another medication. But really, in principle, if something's not working, it's not working. You should probably take it off before you add something else on. But in the real world, that's harder to do often than said. But it is something to have a conversation with your neurologist about, hey, I'm on 4 medications. Do I really need to be on 4 medications? Can I come off some of those medications? And as I said, it's really important to balance seizure control with quality of life. It's not necessary to stop all seizures. Individual brief seizures are not hurting the brain as far as we know, so it really is important to not chase every seizure and balance and figure out the quality of life. And so you do not have to chase seizures in these kids. And easy for me to say that, hard for you guys who are living it to want to follow that. But it just, it's a long conversation I have with families about this and getting people comfortable with the fact that it's okay for the child to have seizures. So what medications have been tried in FOXG1? Again, this is from the Rett Natural History database, and Ellie will show you, had the same list of medications. So basically, all the medications that we use in kids with epilepsies have kind of been tried in individuals with FOXG1. In the US, Keppra or levetiracetam is often a medication that's used. And these 2 up here are rescue medications. Typically, they can be used daily, but are typically rescue medications. And this is the number of individuals who had that. So of I think there's 76 in our population, 26 were on levetiracetam at their first visit. And we have the data for looking across time, but we haven't analyzed that. So that's 26 at their first visit. And unfortunately, just to go back one, that we've been looking at if we could tell whether any of these work better than anything else. And from the way we've collected the data, it doesn't look like that there's any medication that works better than any other medication. One of the questions I always get asked is cannabidiol. And is there anything specific for FOXG1? No, originally I was part of an expanded access program that started with 5 centers around the country, ended up being a lot more, and there was a number of FOXG1 kids in that group, and their response was similar to the population as a whole, which in that group was about 40% would have a reduction in seizures. So it can be helpful, but it's not a cure-all in any way, shape, or form. One of the important things to note about cannabidiol, whether you get it as Epidiolex, which is the FDA-approved version, or you get it from a dispensary, is that cannabidiol interacts in the liver with the enzymes that metabolize other drugs. So it's important to tell your neurologist if you're getting a artisanal preparation from a dispensary or from online, because they need to know that, because it can push up the levels of, particularly of clobazam, but also Depakote. And so it's really important that you tell your neurologist if you're on a artisanal preparation or an online preparation of CBD. I say careful of state dispensaries, because what you're getting isn't guaranteed. And even though they might test it and say this is what it is this time, the next time you go back, you could get something different. So there's a lot of variability. So just be careful with online or state dispensaries. And then we really need to know, does it work for these disorders? And then side effects in kids with neurodevelopmental disabilities could be very unpredictable. Some are dose dependent, others recur regardless. General sense is that newer medications have fewer cognitive side effects. behavioral and mood changes are often difficult to sort out and are necessarily dose-related, particularly like with levetiracetam. And the long-term effects are unclear, but they can impact your child. So this goes back to the balancing the side effects with the underlying seizure control and the need not to chase all seizures. And you want to report anything you see to your neurologist so they know what to do. This is something that you all should be aware of, but have, a seizure action plan and routine seizure first aid. And, for new parents, not all seizures are medical emergencies. When you're first diagnosed, every seizure will seem like a medical emergency. And you can ask the parents who are old hats that they're just like, they're seizing, it's okay. But, there's a balance there. And, you need to, what you do depends on what's happening in the child. And, this is, I put this here because people still, the old wives' tale of putting a spoon in the person's mouth if they're having seizure. Don't do that. Put nothing in their mouth. You've never heard, if no one here has heard that, that's great, because 20 years ago, that's all we heard is, should I put something in the child's mouth? And, you might not have to do anything if it's a brief seizure. You can just watch them and let them get back to baseline. One of the things that's really emerging now is technology to kind of help with tracking seizures, knowing whether a child is having a seizure. And so there's there's a number of technological aids. These are wearable devices or bed-based devices that you can put in that can tell whether a child is having a seizure or not. One of the important things is that, we still are learning how good these things are. And most of these are first tested in adults with convulsive seizures. That is not going to be generalizable to your kids. So be really careful before you go out and buy these devices, because if your child does not have a convulsive big motor seizure, it's unlikely these are going to work. We're still learning. Some of them are trying to train their technology to pick up lots of different types of seizures, but we're still learning about that. And so, be careful with buying these to start, because I'm often told that they're bought and then they just become another thing that sits in the drawer and not used. And the important thing is to keep track of your seizures. Now, you don't have to, like I said, you shouldn't be chasing them all, but it's good to have the information and be able to relay that back to your neurologist so that they know how to make changes or what to make changes on. So there's a couple good websites that are free to use. They have good apps that you can use. I particularly like seizuretracker.com. There's also epilepsyjournal.com. There's a bunch of others out there. Use the one that you think is most easy to use, and the foundation is thinking about trying to link through this to the registry and to the website so that you can have access to these things, but they're available just for free currently. And here's an example of how seizures are reported out, and they can even put in when medication doses change. You can put in when your medication dose change, so you can see correlations between seizures and changes in medication. And you'd be surprised that it's normal human nature that there's what's called a recency bias, right? What happens in the last week is what you remember better than what happened a month ago or 2 months ago. So if you just report to the neurologist, you're going to lean towards what happened in the last week, not the bigger picture. And so having the ability to track the seizures gives you and the neurologist and your pediatrician or whomever kind of a bigger picture of what's going on so you can make smarter decisions in treatment of the kids' seizures. And just the last thing, so from the natural history study, one of the things that we were doing, because this was talked about earlier, is trying to develop a biomarker of responsiveness, ultimately a measure that's non-invasive that will tell us if someone's responding to a treatment. And ideally, you'd want something that will predict whether someone's going to respond to a treatment. That's the holy grail of what we're looking for. And so we've started by using EEG to determine whether this can work as a biomarker. And so we did a couple different things. We did what's called a visual evoked potential. This is where you flash a light and then record the brain waves, and you see the brain's response to the light. And a typical response is the black one here, where there's this triphasic response, an up, a down, and an up response that occurs. And you see that the other disorders that we looked at, none of them have that typical response. So their brains do not respond normally to a visual stimulus. And if you quantify that, the amplitude of this response or the latency of this response, that it's different in all these disorders and slightly different depending on the disorder. Same is true with the auditory evoked potential, but in general, the visual evoked potential was more impaired than the auditory evoked potential. And the last thing is, we had in the natural history study, we had what we called severity scales. These were built and designed for Rett syndrome, but we could look at it for these others. And so if you look at FOXG1 here at the right, the latency of the visual evoked response correlates to the severity of the individual. Now, such a steep curve is driven by this one kid who's mosaic and kind of an outlier. But even if you take that out, that you see that there is some relationship that's building there. So this is a promising start to think about how we could use these EEG-based markers as outcome measure for these conditions. So, future, is there a best drug? Like, is there a way that we can capture data to figure out if there's a best drug that works for FOXG1 for their seizures? Is there a best way to count and follow seizures? Can EEG be a biomarker? These are all questions that are need to be answered moving into the future. And with that, I will end. No questions now?
Great. Now we'll do questions after the next two presentations, and I know I already have 10 of them. So let's introduce Tim Benke, who is from, thank you, Eric. Yeah. We could do a whole day just with our neurology team. And this neurology team, they are our key opinion leaders on our natural history study. So we do have the opportunity to meet with them often, and they are playing such a key role in driving our research forward through truly understanding our patients. So introducing Tim Benke, who's with the Children's Hospital of Colorado. Thank you for being here.
Thanks very much for having me. It's been a great few days, and thanks to everybody. So what I'm going to talk to you about today are top concerns, communication, sleep, and some general approaches. There we go. Those are my disclosures. So the top topics today. So I'm going to talk to you about the top concerns from the NIH-sponsored natural history study of Rett and Rett-related disorders, which Eric spoke to you a bit about briefly, but I want to tell you a little bit more about that so we can compare and contrast what's been done with the citizen-based natural history study. I'm going to talk about sleep issues and approaches, and it's really important that this is the world according to Tim. And there's not a lot of data that's where we need a lot more data to understand that better. And the same goes for communication. And then just provide some general suggestions. So the NIH-funded natural history study of Rett and related disorders has followed over 1,000 patients over 15 years. And as you might know, when it initially started, it also included Angelman and Prader-Willi syndromes. But then it shifted in 2015 to be Rett, FOXG1, and CDKL5. And this was Alan Percy at UAB. He was the principal investigator, along with Jeff Newell for this. And we completed as our funding finished in summer of 2020. And we used some revamped data instruments, but there were also some sub-studies. So the main protocol was this visit where we got a lot of parent data. There was a parental interview and a clinical exam. And then there was this other sub-study where we did the EEGs that Eric was just talking about. And these were the participating institutions and investigators, and there were several sites across the country, as you can see them listed here, from CHOP to Colorado, Boston, Vandy, Rochester, Greenwood, Baylor, Rush, UCSF, and so it was a group across the country. And that's kind of important to some of the next points. But it was funded by the NIH. It was your tax dollars at work. So the inclusion criteria to be in the study was families and caregivers, you had to be agreeable to consent, and it was females and males of all ages, and you had to have had testing done for MECP2, CDKL5, or FOXG1 genetic changes, and meet the requirements that there was an actual spelling change or meet the consensus criteria for typical or atypical Rett syndrome. And so the enrollment over 5 years was 1,000 subjects. This was our goal. But the main thing to look at is our goal was for 50 individuals with FOXG1, we actually had 59, which was really good. And what we did is we followed, if you were under 10, we followed you annually. 10 to 20, it was every 2 years. And if you're over 20, it was every 4 years, twice during the funding cycle. But there were some limitations to this. You had to be close to one of the centers of excellence or willing to travel to be part of the study. And one of the important things about that as well is not only were you willing to travel, is you had 2 to 3 hours to spend with your favorite people. While we asked you the same sort of questions, and you get asked the same questions again the next time, it was a definable condition called form fatigue that you were put through. But not everybody could do this, and the other issue is it also had to do with if your child was really ill, then you weren't going to be able to make it to these sorts of visits. So there were some issues with the data collection. I think we were missing on families that couldn't travel, and also missing on families that could have been more severely affected. So one of the things that we did for the study, and this is all courtesy of Jeff Newell, this was his baby, is parents and caregivers were asked to pick from a list of top concerns and list in order only their top 3. And there was also a free text option. And what this represents is it represents a relative concern and not a prevalence of a symptom. And the concern is dependent upon you recognize the symptom, and it's severe such that you put it into that, and also the duration. And if I were to ask you what your top 3 are today versus 5 years ago or 5 years in the future, your child may be having the same things going on, but you, as Eric said, you might get to be an old hand at fill in the blank, and it's not such of a top concern to you at that point in time. So these things vary. It's a snapshot. And this was all what we got from families, their top concern during the first visit. And so this was then analyzed by the top concern was weighted to 1, the second was 0.5, the third was by 0.3, and then the average weight was computed. And so these are the top concerns. And so the top concern was communication, followed by sleep, feeding, balance, constipation, abnormal movements, hand use, reflex, and vision. So just take that in for a second, and there's going to be a big caveat here in a second. And this is the rest. And you're going to look at those, and you're going to go, but my top concern is really bruxism. Why was that not in the top list? And it really has to do with how the data was collected. It could have been your top concern, but overall, it was not the top concern when we did the analysis this way. So it's important to look at what was the first concern for people, because I think you learn a lot from the data. And so the first concern for people was 20% said seizures, and then 17% said communication. Now, because the sample was of a certain size, is seizures really different from communication? I think they're really battling it out there at top 1. But then there's a clear separation. Then the next one is walking and balance. Oops. The next one is walking and balance. And then if you look at abnormal movements, chewing, and sleep, these were all rated by 6% as the next thing in the first concern. Then vision, reflex, constipation, weight gain, other GI was at 3%. So these are all somebody's top concern, but it was a smaller percentage of the total group. And then this is the next list, which is a much longer list. So 2% were still reporting all of these things as their top concern. So it doesn't, just because your top concern wasn't in that list with the weighting, it doesn't mean that somebody else didn't think it was a top concern. So why is this important? It all comes back to the FDA, because clinical trials must focus on outcomes that are meaningful to feeling and functioning, and that's their words that they like to use, in affected peoples and families. And the outcomes are, well, which symptoms are important, what changes in these symptoms are meaningful, and can these changes be measured in a clinical trial? So we can statistically say, oh, we got a change in a clinical trial, but was that little increment enough to be meaningful to you is an important distinction. And then the next big thing is can I measure that in a clinical trial? And successful trials need meaningful outcomes that can be measured. So we could talk a lot more about what that particular measure might be, but this is the first principle, what is important to families. And so I think that with what Ellie's done and what we have here, we're on our way. So I don't want to spend too much time on this because I think we want to hear from Nadia, but one example that we have is our Rett clinic, and it's everybody with MECP2, FOXG1, and CDKL5 changes. We have a big group of people. It works for our part of the country because people feed the cows at 2 o'clock in the morning and then they jump in their car and come see us. And so it's useful for them to get all of their visits done in one day. That sort of fire hose is not necessarily useful for everybody. And we've got a nice space in the hospital to do it. We get support from Rocky Mountain Red Association and from the International Foundation for CDKL5 Research. But what's key to our clinic is we have a nurse coordinator. How do we raise money? It's Colorado. We do fly fishing tournaments. So when you're done raising your $100,000 for FOXG1, come fish with us. So in our children's clinic, so I've got 10 families from Colorado and the surrounding states. Their ages 3 to 20. 10 families does not make me an expert, okay? But this is what I've seen. So the common features for everybody is epilepsy, communication, sleep, mobility, cortical visual impairment, the abnormal movements, and the GI issues. And so the things that I've been asked to talk to you about are sleep. And so the big question is, well, how do I know that sleep's really a problem for you? Well, one of the things is, and there's a typo here, is the sleep scale. So you guys have been filling out the Childhood Sleep Behavior Questionnaire, not CSBS, CSBQ. There's another scale called the Bruni. I've been doing the CSBQs in the Rett clinic for a long time, but I found that they don't necessarily tell me what's going on because I probably am not using them correctly to add up to get a score. But this is my money question. It's how many nights per week do you have to resettle your child at bedtime? If you're saying more than one or more, then it's too much. And so the additional questions are, is it getting to sleep? And these are the questions that I have to ask you or your clinician needs to ask you. Is it getting to sleep, staying asleep, or both? So getting to sleep is initiation, staying to sleep is maintenance, and it can be both. And the other big question is do they snore and do they nap during the day? And these are clues that if there's other reasons as to why you're not sleeping well at night that need to be investigated further. But then also, what keeps them from sleeping? You go through the list. Is there something going on with the GI system is primarily one of the issues. Is it seizures, et cetera? But then it's also a lot about the environment. What kind of bed do they have? Is it, just, are they still in the crib? Or do you have a special bed for them? And I think that this is, and what are the blankets like? There's a lot of things that you can ask. So you got to get the mood right. Is the mood right at bedtime? So you have to set yourself up for success. And so it's appropriate bed, appropriate blankets. And if you don't have what you need, then you need your providers often to write letters of medical necessity, which is, one of the issues here is that your insurance company isn't going to do it unless you jump through all of the hoops to get the paperwork in line. A sleep study is needed if there's snoring or excessive daytime sleepiness. Sometimes your child might need something like their tonsils out, but they may also need something else to help them to sleep, like oxygen or positive airway pressure, and sometimes that's really hard to tolerate, but there are ways of desensitizing you to get used to these sorts of equipment. So there are medications for initiation. Primarily this is melatonin, but I think that with most folks here, it's not about getting to sleep, it's about staying to sleep. And so there are medications for both maintenance and initiation, and my favorites are clonidine, gabapentin, and trazodone. All of them work? No, they don't. So my approach is you try one, then if it doesn't work, have a plan for coming off of it and going to the next one, and so on. And you keep trying stuff till you try to find something that works. And then there are additional medications that were listed from the natural history study that people have used, and this is chloral hydrate, Benadryl or diphenhydramine, sertraline, and zolpidem. Chloral hydrate is of course, impossible to get these days. And then there are additional medicines that I found that our people were using at Children's, and these use risperidone, but also artisanal CBD and THC preparations, and which opens the can of worms that Eric already opened. And the issue is that all of these have a variable response. And there's other things that I think that are worth trying. And I'm always open to trying something new because I know how your lives are affected with not going to sleep. And there are these now new things called melatonin antagonists. Oh, sorry. I think we are going to put the slides up so you don't have to take pictures. So the next thing is approach to communication. So I ask questions, well, how often is speech therapy? Is it useful? And one of the good questions was, well, if I do all of this, is it doing anything? And we don't necessarily know the answer to that, but I think it's a good question. But we all know that if you don't push it, the reason why you should push it is because you're going to notice that your child's frustrated because they have something to tell you. And your problem is you don't speak French, and that's the problem. If you could just learn to speak French, then you could understand what your child is saying. So one of the things that I ask families to try to understand in their child is tell me about their yes mannerism. Tell me about their no mannerism, and who can recognize each of these. And if you can recognize it, then you can teach their circle of teachers and their circle of friends and family to recognize those mannerisms as well. It's a good place to start, is to try to figure out their yes and no's. And are they using assistive or augmentative communication? And is your speech language pathologist comfortable with it? Because those are two very different things, as you know. And is this used at home and school? And a lot of times, oh yeah, she's using it at school, but it hasn't come home yet. And it's like, okay, great. Well, yeah, we have it at home, but I don't want to turn it on because I know what he wants already anyway. So as you can tell, these are my pain points, if you will, that these things need to be used consistently in order to be effective. Has cortical visual impairment been taken into consideration for whatever the device is being used? And I know Christine Roman-Lancey is going to talk more about this. But also the other point is was the teacher of the visually impaired involved in setting this up? So my approaches and what we see in our clinic is people are using iPads, they're using Tobys, they're using head switches, Big Mac switches, and then also homemade versions that you can make with a 3D printer. I can tell you more about that later, but basically, you know those really sweet switches that cost $80? You can make them for under $3 with a 3D printer. But what are the uses? Yes, no's, they're making requests, they're requesting the sort of music that they want to listen to, which is not what you like. They're activating toys, games, they're getting attention. And what I think needs to be more of is people to use yes-no cards and to work more on gesture recognition. I think there's a lot more that we can push and get done there. And so how do we do that? Sorry. And the challenges are that the devices are bulky, they're unreliable, and they're cost. How many times have I said, well, yeah, we have a Toby, but it's in the shop? It's just 50% of the time, it seems. So these are my approaches. Now, I'm not going to read all of this. You can just pull this slide off. But basically, I blow this into my note that you take home with you. But it's the sort of thing that you can all use. But the key thing here is that there is guidance. It's online. It's something that now International Rett Syndrome Foundation has set up for your speech language pathologist to do. And if they do it, they get free continuing education credits, which is a bonus for your poor speech language pathologist who can't afford this. They can get it for free. But there's also things, if you can look at these videos too. There's no barrier to looking at them. But there's also some other resources about learning yes, no. And so these are, I think, are very useful for families. I also have this blurby thing that I put into my note about therapies. And it's got a lot of legalese in there, and I'm trying to remind insurance companies and schools that they have an obligation to your children with regards to what they provide in school. School is not babysitting, school is education. And then I also have another blurby that I like to put in about cortical visual impairment with also some useful things. And again, there's a lot of issues surrounding what the school has to do by federal law in order to take care of your kids. So what to do? The bottom line is that there are no proven approaches to sleep and communication. This is an unmet need. It's only through trying to do things systematically will we come up with the answers to these questions. But I think it's important that you working with your clinicians, you work on things and try things. And when it doesn't work, you say, okay, what's next? But give each thing a good try, especially with the communication. I think it's really important to be consistent, especially with sleep, with setting the mood at home. It's important to be consistent. Medications for sleep, start low, go slow, move to the next. And like I said, be consistent with communication. But the bottom line is, as I put there, you're always going to be the best advocate. Keep in touch with your clinicians, and I think that's the approach I'd suggest. So thanks to everybody, especially our FOXG1 families and my team, and those people that I had the privilege to work with the Natural History Study. So thanks very much. And then I would take questions, but we're going to do that later. And do you want to talk about the standard of care slides now, or maybe wait till later?
Let's bring it up in the questions.
Okay, perfect.
Yeah. Thank you so much, Tim.